Hello, welcome to this spinal care update. I'm Captain Dale Johnson, Johnston County EMS Training Officer. It's September 2015, and this is just an update on the changes that are coming to spinal care for trauma patients here in Johnston County. What we're going to be doing really quick in this update, review the EMS system spinal protocol and procedures, review the benefits of reducing the use of the long spine board as a mobilization and transportation device, and review the techniques to be used to reduce long spine board use in Johnston County. So back in March 2015, we reviewed the new spinal care update, and basically we reviewed the lack of benefit from transporting patients on long spine boards. We reviewed the actual harm that arrives from allowing patients to remain on and be transported on long spine boards. We reviewed the alternatives, and we went over our EMS system proposals. Okay. Since then, concept was rolled out to all four Johnston County EMS agencies and was introduced to the Johnston County Fire Departments by way of the fire chiefs meeting. We submitted the proposal to NCOEMS and to the NC EMS Medical Director for review and approval. We ordered new head blocks to use with the new method. The current head chocks, as I call them, wouldn't work because of the adhesive pad that would prevent sliding the board out from under the patient. And most recently, the policy, procedure, and protocols were received back from NCOEMS with full approval. So we're ready to go. So just a really quick recap. All of this, what we've been doing for the last 40 years in EMS, was based on one study done in the early to mid 60s by a guy named Geisler. And he looked at incidents during the 1950s, and he was trying to explain the incidence of spinal cord injury from mostly motor vehicle crashes. One thing he did not consider was there was an absolute lack of field care in that era. There was no EMS, and in many places, particularly your small towns, there was not even a physician in the emergency department. If an injured patient came into the emergency department, they had to call somebody to come in. Also, it didn't take into consideration that the motor vehicles of the era had no safety features whatsoever. No seat belts, no crash zones, no airbags, no anything. Big metal dashboards and just horrible. One study that came out in the mid 60s suggested use of long and short boards as a means of extrication, but that study specifically did not say anything about leaving patients on them. They just were mentioning using it as an extrication board. Beginning a formal EMS back in 1971, the American Academy of Orthopedic Surgeons, they first published their guidelines in the book Emergency Care and Transportation of the Sick and Injured, which was one of the first two EMT textbooks. And they advocated the use of long boards and seat collars in patients with signs and symptoms of spinal injury, and they based that in part on the 1966 study. Okay, and that was it. Um, there was not a whole lot of information to go on, but it kind of started in 1971 was when it all came about. During the 70s, it was decided that doctors were underappreciating spinal injuries. Okay, again, there was no mention of field care or lack of during this time period. And even though emergency was on TV in 1971, EMS pretty much around our area didn't really get started until the mid 70s. And there were even parts of North Carolina that did not have really good EMS until probably into the 80s. But then in the 80s, it was suggested that maybe patients ought to be immobilized based on mechanism of injury only or the potential mechanism of injury. The thing to keep in mind is there was never any study to look at the potential benefits of spinal immobilization or even if it worked. We didn't look at that. It just, hey, it sounded like a good idea at the time. And anybody who's been involved in pre hospital care, emergency services of any kind, you can name plenty of stuff that we've done over the years. I can recall lots of emergency care procedures, firefighting procedures that we have done in the past because it sounded like a good idea at the time, and that was it. Is there any evidence of benefit of spinal immobilization? Well, first off, there's never been a randomized controlled study done ever. There's not been anything done to say, hey, this works, this is good. But there's evidence of harm. There's lots of evidence of harm. Lots of evidence. Um, Numerous studies have determined that long spine board cause respiratory compromise, restricting your ability to breathe, pressure sores by just laying on one for 30 minutes, increased pain, distracting injuries, and we're x-raying people and expose them to radiation when they don't need to be just because they're on a board. Numerous studies have determined that spinal immobilization does not really immobilize anything. And then there's all the studies that have determined that these bad effects that are listed above, they're even magnified in kids. So yeah, there's a lot of harm involved in it. We should not be immobilizing penetrating trauma patients at all because there is a distinctive increase in mortality when we do it. These patients, they obviously need to get somewhere to be taken care of sooner rather than later, but we're taking a lot of time to immobilize patients, and there's a definite relationship between immobilizing penetrating trauma patients and mortality of penetrating trauma patients. Several national organizations, they're listed below there at the bottom: American Academy of Neurologic Surgeons, American College of Surgeons Committee on Trauma, National Association of EMS Physicians, National Association of EMTs. They've all come out with position papers saying, hey, stop this, stop it. Okay, and we're going to. Numerous studies have determined that the incidence of death is greater in patients who are immobilized versus those who are not, who are experiencing, have been shot, stabbed, or something like that. There's no benefit of immobilizing these patients of any kind. Somebody will say, well, you know, Dale, they've been shot. They've been shot in the spine and they're paralyzed. Yeah, that's final. You're not going to fix that. And we're spending time immobilizing them when we need to get them to a surgeon to get the bleeding stopped and all that. All right, there's no benefit. And again, you got all the position papers from these national medical groups, and these are not run-of-the-mill groups. These are the experts in the field that have said, "Hey, guys, stop it." Okay. 3 points of contact for long spine boards. When you are laying on a long spine board, you've got contact in the back of your head, back of your shoulders, and at your sacral area, sacrum. Okay, that's it. You got all these voids here. And if you're looking from down this way and you look at the patient, there's terrible amounts of space that allow for movement. So there's not a lot of support provided there. All right. And what we did, we painted one of our cadets, put one of them Tyvek suits on, and painted her up with red paint. We did learn that those suits leak, so be wary of that. Later on a long spine board, we wrapped the spine board up with a sheet, but we laid her on a spine board, and you look at the absolute really lack of support. This is her head, this is her shoulders, this is her pelvic area, and these are her calves. Okay, not a whole lot of support there, and there's none at the sides. I mean, you slide back and forth and everything else. Another view here, these people, the ProTech people, were trying to sell a $150 backboard pad that was not very durable. But you can see someone laying on a long spine board, there's still not a lot of support there. Okay, this is a 160-pound male, um, laying on a board. Not a whole lot, not a whole lot there. So just how well do long spine boards immobilize? Numerous studies since the 90s have determined that even while supposedly immobilized, patients are still able to experience a great deal of movement in all directions, forward, backward, side to side. They can still move a lot. Strap tightness cannot overcome the ability to move, and when you actually strap someone down tight enough that they can't move at all, they can't breathe. So what's the point? Um, they're, they're just, they don't immobilize. Now, keep in mind there are some limitations on these studies. These have all been done on cooperative patients, healthy volunteers, cadaver models, And they've never done a study on evaluating patient resistance and its effect on the spine in injured patients or compromised patients, which is probably not possible in an ethical manner. But if all these problems are caused in healthy people, what are we doing to compromised and injured people? One other thing to look at: what extrication techniques cause the least spine movement. Basically, several groups use motion capture video, which is how they make the animated movies from actually taking video and they transfer it to the animation. And basically, what they found out was that the standard methods that we use actually create more movement. There are a lot of patients that we put on a long spine board that really put a collar on them and let them get out of the car, and it'll work just fine, and they actually get less movement. One of the things that I take from this is we need to really seriously look at our extrication methods. We spend a lot of time, well, let's just pop the door. The car's totaled, the vehicle's totaled, and we're just going to pop the door. And we're trying to wiggle these people out. It creates lots of movement. We need to start looking really hard at just popping the top off and go at it from that way. For years, I've heard people talk about, man, I wish we had a padded long spine board, and we've already got it. We had it, the EMS cot. They're essentially long padded spine boards. Once the patient's secured on the cot, the board's redundant, serving no purpose at all. The ambulance cot prevents spinal flexion and rotation and lateral motion. It provides support. It conforms to the anatomic shape of the spine, and it's got a non-slick surface with the sheet and all that keeps the patient from moving. And basically, transport on the mattress is without any of the downside risk of the long spine board. We repainted that volunteer, laid him on the cot, and lifted him off, and you can tell a world of difference just from this one picture. You've got support up on the sides to prevent that lateral movement. Okay, and just look how much more support. You remember in the other one there was just a little bit up here, and you're filling in a lot of these voids now. And then here's a comparison. This is the ambulance cot on this side on the left, and you just see so much more support that's offered as opposed to the long spine board on this side. If spine boards were a medication, if I were to introduce a medication with the same risk and benefits as a long spine board, they would stop. They tell me not to do this. No, you can't sell this drug anymore. And there's been several drugs in our history that have come out, and they determined that there's a lot of risks with very little benefits, and they stopped them. Fen comes to mind. Yeah, it helped you lose weight, but it also caused heart attacks. Quaaludes, they were real good, sedative and hypnotic and all, but there was a lot of side effects of that. So if spine boards were a medication, we wouldn't do them at all. Potential benefits from not using long spine boards: reduce the amount of on-scene personnel, because a lot of patients that we put on boards we're not going to do. Just let them sit on the cot. Reduce the amount of patients lifting from the ground on a long spine board who are already ambulatory. The translation of that is that standing takedown stuff we've been doing, stop. We don't need to do it. Reduce the amount of awkward positions. Think about the positions we get in to try to extricate patients who are otherwise well and could probably get out on their own. Keep in mind, there are going to be patients that we have to extricate. We understand that. And we're going to extricate them on a board and with a KED. We're still going to do that. Just once we get into the cot, we're going to get it out from under them. Reduce scene times, because it's a whole lot quicker to do this. Just put them on get them out, set them down, strap them in, and go, without doing all the long spine board stuff and everything else. And think about the cost of replacing all those long boards that have disappeared. When I started working in EMS in Johnston County in 1994, I'm trying to think of all the long boards that have disappeared. I wish I had $1 for every one of them. Okay, I would have a good amount of money and could probably take a nice vacation. Some of the benefits: more comfort for the patient. Speaking from someone who laid on a board for an hour and a half many years ago, I can tell you, um, laying on a board hurts. It hurts really bad. A lot of nurses will tell you, "Hey, we get patients in the ER and we get them off the board right away." And most nurses I know of, they try to do that. Most doctors I know of try to do that. But there's always that one ER doc that he's either busy or something, and you get to lay on that board for an hour. We're gonna we're gonna save you from that situation. We're not gonna nuke you as much. You're not gonna be exposed to a lot of X-rays that you don't need. That's gonna decrease costs right there. And healthcare cost is a big thing these days. No matter what side of any of the debates you're on, healthcare costs are a significant issue. And anything that we can do to reduce costs without increasing risk, we need to do that. And then also, there's there are situations where, okay, let's put a collar on them and set them on a stretcher. But pretty much we've been in that mindset. Well, if you put a collar on, you got to do the whole package. Well, we're going to eliminate the whole package. If you got a patient that just needs a collar, we can do that. Because even if you put them on a board to get them out of a bad situation, once they get to the cot, they're coming off the board. We're not alone. A lot of places are doing this. Lots of places in North Carolina have implemented this approach within the last 12 to 18 months, and many more are coming. Um, and it's been in use around the world. Australia has not transported anyone on a long spine board on the whole continent since the mid 2000s. In Europe, Canada, they've done away with it. And most recently, probably the biggest system to adopt this approach is the city of New York. So this is not something that we're making up. There are a lot of places that are embracing this. So what exactly are we doing? We've got a precautions policy, a procedure, and a protocol. The protocol is basically a C-spine clearance that's more a method of inclusion into this and rule out causes. The spinal precautions procedure, which is the document in the middle, is actually, I think it wound up being 7 pages. There are 4 basic procedures: extrication and use of a long spine board, KED in a long spine board, scoop stretcher, or just putting a collar on them, letting them stand up and sit on a cot. Regardless of that, whichever method you use, the board comes out from under them. We're not transporting patients on a long spine board except in 2 cases, and I'm going to get to that in just a couple of minutes. All right, but we're just not going to do it. All of these, we're getting the patient off the board. So we may arrive on the scene. For example, fire department arrives on the scene first, and they extricated the patient from a car or got them out of a construction incident, and they're and you got them immobilized on board. That's cool. Um, just understand, once we get them to the cot, we're getting the board out from under them. All right. So the way we're going to get the board out from under folks is this. Um, this video is listed as method number 2, but notice you've got one person. This is a average size patient. Got one person up here kind of providing support at the shoulders, and one person here in the middle, kind of stable, keeping them stationary at the hips, and you just sliding the board out this way. One of the reasons we had to change types of head blocks because that adhesive pad that we used to stick up here at the head obviously wouldn't slide out from under them. Okay, and then we just slide it on out from under them. They're good. We get the straps on the stretcher, put the handrails up, and we strap them on down, and we are ready to go. All right, nothing to it. So, does this method work with larger patients? Well, actually, it does. Notice one, you've got one person here, and she's probably having to struggle a little bit. You know, pretty big guy here. You got two people up here that are helping stabilize his upper body and um, head area. And if you saw that quick little thing, the guy, it's going to take some effort to pull that board out from under the patient, but still, it comes right out. All right, there it goes, and they're on it, and you put the straps on, and we're ready to go. Whole lot easier and more comfortable for the patient. So, what exactly is changing? We are still going to exercise spinal care precautions on trauma patients. We use the board as a extrication, but you know, that's what we're doing with it. We're using it for extrication. We're still going to use long spine boards to move patients from point A to point B being the cot. Then we're going to remove the board out from under them, except in two cases. Unresponsive blunt trauma patients, this is the person who's been involved in a motor vehicle accident or they have fallen from a great height and they're unresponsive. We're going to leave them on the board. And then your unresponsive post ROSC patient, cardiac arrest patient that we've got pulses back on, we're going to leave them on the board if they're unresponsive, because we want to have that surface to do CPR on. There is simply no other reason for leaving anybody else on a long spine board during transport, especially when you consider all the potential problems. Got a pregnant patient, obviously. There's the thing about the third trimester patients. We want them on their left side. Okay, put them on their left side. Do it just like this. You got someone who's vomiting, put them on their side. Uh, you can immobilize somebody, for our purposes. This provides all the needed support, all the potential restriction of motion that we need. This works. Been teaching this for a long time to folks, and it works. Spine boards is modern art. This is probably one of the best uses for them. We're still going to have some, for extrication purposes, but we don't need anywhere near what we've been using. And, get a good one that's rectangular all the way around, make a good coffee table. The kits that you can make the 2x4 benches out of, all you need's 8 bolts, nuts and washers, and 2 good backboards, and you can make a nice bench out of it. There's going to be one of these benches on my carport in the not too distant future. So we're trying to get away from this, and this picture is from here in Johnston County, and I don't fault anybody. When this picture was taken 2 years ago, this is what we've been doing. This is what we've been taught. But really, is this guy mobilized? No, he's not. He can still move. He looks like he's pretty comfortable drinking a bottle of sterile water. Don't know too much about that, but still, we're getting away from that. We'll still use the board maybe to get him up off the ground and get him to the cot, but then the board comes out from under him. All right. So thanks for taking the time to watch this. If you have any questions, please give me a call. My number's there. My email address is there. I welcome any questions you have. We'll get it worked out. I know there's going to be some concerns initially. It's change. It's something different, and it goes against everything we've been taught for 40 years. And I understand that probably better than anybody because I've been doing this. This September makes 40 years that I've been doing this. And I know change is hard sometimes, but we got to do what we really think is in the best interest of the patient. So thanks. If you have any questions, give me a call. I will come out and do whatever I need to do to help you through all this. And everybody be safe out there. Have a good rest of your day, and we'll talk at you later.